How do you classify scoliosis? When it comes to the diagnosis of scoliosis, certain parameters must be met. First of all, scoliosis is an unnatural sideways spinal curvature. It has to be present. And normally this unnatural curvature needs to be 10 degrees or greater in a Cobb angle measurement. In addition to the angle being there, there must be a rotational component. And this rotation is typically into the concavity of the spinal curvature. So 10 degrees or greater with rotation is what the definition of scoliosis. Now, scoliosis is classified into many different types. It helps us determine the assessment associated with the scoliosis, and it helps us determine key variables to help classify the scoliosis to get predictable outcomes for treatment. When we classify medical conditions, this really helps us streamline treatment processes and helps us deliver which routines or which process is most significant or provides the best outcome for certain types of scoliosis. In the classification points, we look at several different things. We look at, number one, the patient age. We look at the condition type of type of scoliosis, meaning causation or associated causation. We look at the severity of the scoliosis, and we look at the location. Now, patient age is a key factor. And the reason why patient age is a key factor is because it's what also helps us determine, is the patient maybe experiencing pain, and also is this curve likely to progress over time. Scoliosis is not painful in children because it doesn't become compressive until the adult stage, and this is when curves progress as a result of gravity. In children, curves progress as a result of growth. So in this growth stage is when curves can actually start to progress, and when they go through this pubescent growth spurt. But in the patient age, when we look at in the adult stage, this is when we kind of have to consider, is the patient in pain, and is pain management or pain reduction going to be one of the things that we have to focus on the treatment. Also, when we look at age in terms of rate of progression, like I mentioned, we know in this adolescent growth spurt is when curves tend to worsen. And as a progressive condition that can worsen rapidly during this growth phase, we have to understand that since this can be the number one trigger for progression in this growth phase, we have to look at how much risk is this patient going to be for rapid progression. So there may be more extensive monitoring or progression done at a smaller time, because we want to make sure that this curve doesn't progress rapidly during the growth phase. So in patient age, we're looking at whether they're adolescent during growth. In the adult phase, could they possibly have pain? Now, really, the age is broken down into several different categories. So the initial category is infantile scoliosis, and this is when the diagnosis is made between 0 and 2 years of age. Between 3 and 10 years of age, this is when we call it juvenile scoliosis. Between 10 and 18 roughly, or until the patient is skeletally mature, this is when we call it adolescent scoliosis. This is the majority of the time when scoliosis is diagnosed. 18 plus is considered adult scoliosis. Now, I also like to have a last category there, and I call it late stage adult or later life adult. And this is like 50 or 60 years plus. And the reason why I like to have this other category there is because curves can start progressing in later life faster again. So in this adolescent stage, they can progress rapidly. And of course, in this later stage life, they can start progressing rapidly again. And now also in the later stage life is when they also start to experience pain and discomfort as a result of scoliosis. So therefore, those are the classifications in terms of age. Now, we also look at classifications in terms of the different types associated with scoliosis. Now, when we think of a type of scoliosis, what we're trying to associate is a causation. And this is only when it's known. Unfortunately, the most prevalent form of scoliosis is something called idiopathic scoliosis. And idiopathic scoliosis is when there's no clearly associated cause with the scoliosis. We believe idiopathic scoliosis is a multifactorial problem, meaning there are many, many different variables and many different factors that can lead to a curve actually developing in a child or an adult. The most common finding in terms of idiopathic scoliosis is adolescent idiopathic scoliosis, and it's by far the most prevalent form of scoliosis that's diagnosed, and this is because this is when it's found. Now, do we think adolescent scoliosis may have been there in the juvenile years? Yes, but it's normally diagnosed in that stage. So since it's diagnosed in the adolescent stage, this is when they call this adolescent idiopathic scoliosis. Idiopathic scoliosis accounts for approximately 80% of all diagnosed cases. The remaining 20% are normally broken down among other categories. And one is something called neuromuscular scoliosis. Neuromuscular scoliosis is when a patient has a neuromuscular condition and they could possibly develop scoliosis. Neuromuscular conditions can be connective tissue disorders or can be a neurological condition that could be associated with the causation of scoliosis. Now, in a neuromuscular scoliosis, sometimes the condition, the neuromuscular condition, must must be treated before you treat the scoliosis. In other cases, you treat the scoliosis like an idiopathic case, meaning the neuromuscular component can't be treated, so you treat the curve like a curve. Another type is something called congenital scoliosis. This is truly when you're born with scoliosis. This is in utero. One of the vertebrae doesn't fully develop into a normal shaped vertebra and develops into something called a hemivertebra. This hemivertebra is present at birth, and it leads to a curvature developing. This is called congenital scoliosis, and this is about 5% or so of cases. Now, congenital scoliosis can be a wide variety of presentations and severities. Sometimes it can be difficult to manage because you actually have a structural abnormality that's happening at birth. And then the last one is something called degenerative scoliosis. Degenerative scoliosis occurs is a scoliosis that did not exist in the adolescent stage, but only starts to occur in the adult stage. And it happens because of asymmetrical degeneration that's starting to develop in the adult stage, which can lead to a curve progressing. More common in females, it tends to happen post 50 years of age. It can happen in men post 60 to 70 years of age. And normally the number one symptom that brings this out is pain. Now, there is something that we also like to talk about is typical versus atypical types of curves. Idiopathic scoliosis cases are normally associated with a typical curve presentation, meaning the most common type being a left lumbar, right thoracic curvature, any combination of those two. When we see an atypical curve, meaning a right lumbar or a left thoracic, we're typically looking at more of an atypical presentation, which is more likely to have an underlying cause, neuromuscular, congenital, degenerative, something along those lines. Now, not always the case. Somebody can have an atypical curve and it can still be idiopathic, but that's just a rule of thumb that if you see an atypical presentation, you definitely want to be looking for other things because they're more associated with these types of problems. Based upon the curve type, it helps us determine the treatment plan to help most appropriately treat the patient that when they come in with their scoliosis and wanting to achieve a proper outcome. And then the last thing that we look at, or the last two things we look at, is severity and location. Now, the severity of scoliosis is normally determined by the Cobb angle or by the size. And the measurement of the Cobb angle is what's taken on an X-ray. And this X-ray is typically taking the most tilted vertebra on the top to the most tilted vertebra on the bottom of that curve, and it's expressed in a number of degrees. And this degrees normally means that the higher the Cobb angle, the more severe the scoliosis condition is, or the more severe the curve is. Scoliosis are typically classified into three categories. I like to use four, though: mild curvatures, moderate curvatures, severe, and something I call very severe. Mild curvatures are anything that's less than 25 degrees. Between 20 and 40 to 45 degrees is considered a moderate scoliosis. Anything over 45 degrees or so is considered a severe. And I like to use very severe scoliosis when curves start to break 80 degrees. And the last thing we use is a location to tell us exactly where the scoliosis is. Now, very often we'll say severe thoracic or severe lumbar. These are things that you'll hear. So what that's telling you is where the scoliosis is located. Scoliosis can occur in any part of the spine. Cervical is in the neck, thoracic is in the middle back, lumbar is in the low back. Now, there's a fourth type called thoracolumbar, and that's when it happens in the transition between the thoracic and the lumbar spine. Like I said, it can develop in any combination of sections of the spine, and very often scoliosis can occur in two sections. You can have a thoracic curve and the lumbar curve, like an S curve. You can have three curves. You can have four curves. There's no rules to say that you only have one curve. In fact, majority of patients will have more than one curve or have three or more. Very often the diagnosis will just be on the largest curve. They'll say you have a severe thoracic scoliosis. Now, the section, it's dictated by the apex of the curvature. So if the apex of the curvature is in the thoracic spine, they'll call it a thoracic scoliosis. If it's in the lumbar spine, they'll call it a lumbar scoliosis. The most common association with scoliosis is thoracic. That's what people tend to think when they think of a scoliosis is in the thoracic spine. And the most common type is going to be, or the common direction will be a right thoracic curvature. Now, curvical location and severity help me concentrate my efforts on what curve I want to reduce and what curve we want to reduce first, and also tell us what type of treatments and therapies we want to do in terms of the severity of the condition. And it also tells me if it's likely to produce symptoms, and also is it more likely to progress. Across the board, The more severe the scoliosis is, the more likely it is to progress in any stage. So mild curves are much less likely to progress than moderate, moderate more likely to progress, less likely to progress than severe, and so forth. So in all age groups, in all sizes, all age groups and all types, we know the smaller you can keep your curve, the better off you are. Now, as a result of scoliosis being so complex, what we want to do is really manage the size of the curve, meaning that if we can keep the curve down and reduce the curve and keep the curve smaller and not just trying to slow down progression, but actually reduce the size of the curve, like I mentioned, we can definitely alter its progressive rate and the risk of the curve progressing. And if the curve doesn't progress, it's less likely to cause more and more complications and symptoms. So we craft very specific treatment plans around all these variables to impact the scoliosis on every level. Thanks for watching. I hope you found this information helpful. If you'd like to hear about other topics and information on scoliosis, type in the comments below and let us know. And finally, subscribe and hit the bell icon to be notified of when we publish content. Thanks.